Hi, welcome to Mad Medicine with Miss P. And if my camera shuts off again, I'm going to chuck that mofo across the room. I just got back from Verizon. I tried to video earlier today and no go. It kept shutting off after a few minutes, or even better, I got deep into it and then it just shut off. So if it happens this time, there will be no video this week, and I'll see if I can wait a week to cool off and start one next week. I know I need a camera. I just doing it through my phone is stupid. I get it. Blah, blah, blah. There's nothing I can do about it. I can't afford a camera. I got a $3,000 vet bill. Anyway, so we're going to talk about antidysrhythmics this week, and without getting too deep, I made myself a couple notes because I'm not going to flip through the book. Although I will say this is the better book. Is it backwards when you look at it? I don't know. I'm retarded. This is the nursing guide that we use, Mosby's, with the students, or I did anyway for years, and that's the one I like the most because the actions are really specific and they make a good. They have good explanations, so you can kind of understand what we mean by action. And I really thought about bringing my little daughter's whiteboard over here and drawing you a QRS, or God, I should have just drawn one to hold it up to kind of explain where the areas are that we're talking about when we get into these antidysrhythmics, kind of where in the heart they work. And that translates to the electrical tracing that you can look at as well. So even if you can't look inside the body and see, where it's working and what it's doing, that electrical tracing kind of explains where it's working. So if you have a little bit of an idea of, your PQRST, you understand that the P is the atrium's contracting, that's the SA node firing, and then your QRS is kind of your getting to your AV node, your bundle of His and Purkinje fibers, and that is the ventricles contracting, and then your T is kind of your resting or refractory period, so it can do it all over again, because as we know, any muscle that is working out needs to rest as well so it can repair and go again. So the antidysrhythmics that I found, or that I kind of thought of the ones we see most often, Cardizem is always in there also, even though it's a calcium channel blocker. Sotalol is in there also, even though it's a beta blocker. But if you understand how they work, it makes sense that they are in fact antidysrhythmics, even sort of atenolol to an extent. But the ones I want to talk about today is digoxin, and you'll see that a lot, lanoxin. And the way it works, without getting all real clinical here, don't overthink it. It's I kind of describe it like if you, when you read it out of the book, the students read it out of the book and it's all these expensive words. It says like I kind of shortened it, but it says that it prolongs the action potential, and I'm sorry, that's amiodarone, that it decreases or inhibits the sodium calcium ATP pump, increasing cardiac output, causing a positive ionotropic effect, which is force of contraction, and a negative chronotropic effect, which is a rate of contraction, and it decreases AV node speed. In turn, the way I describe all of those, expensive words, it's real simple. I kind of picture your heart in a canoe in a gator infested canal where you've got a hole in your boat and you've got a teaspoon, and you're like, good luck. So what's going to happen, right? You are going to try to empty that canoe as fast as you can with your teaspoon and get nowhere fast. You're spitting out a tiny bit of water or blood faster than it can get into the boat. You're going to become erratic, fatigued, and hypertrophic, right? By just kind of, going over and over, and it's not nearly as effective versus someone handing you a big giant bucket and saying completely fill it and completely empty it, and completely fill it and completely empty it. You become rhythmic, you become effective, and you're not going to be nearly as fatigued. And using, let's say, both hands, you're not going to have that risk of hypertrophy of that, arm getting larger on one side than the other, that one arm getting larger on one side. So that left ventricular hypertrophy, if controlled correctly, that should never happen, right? So that left ventricle shouldn't have to be pushing against pressure and, pumping against pressure and pumping too quickly versus the other parts of the heart not doing their job. So when you completely fill and completely empty the heart, you're in turn increasing cardiac output. You're slowing down the rate of contraction so you can completely fill and completely empty, and you're increasing the force of contraction so you can spit all of that blood out of those ventricles and be more effective. So it significantly increases cardiac output and messes with your heart on an electrical as well as electrolyte kind of discourse there. So it works really well. And when you see digoxin hanging, so like I said all the time, if this patient comes in with AFib with RVR, and I see that on the intake that's what they were diagnosed with, that's what they were admitted with, that was their admitting diagnosis, and we go into the room and I see dig hanging, I already know their blood pressure was too low in the ER or upon admission to tolerate cardizem, because like I said before, that would have been our drug of choice. So when I see dig or amiodarone hanging, I already know that this is a heart patient and their blood pressure was too low to tolerate the cardizem, which would have been our first line or first choice of medications. So when you see somebody on dig, I don't care what they say. I don't care if they think they're taking it for weight loss. Don't even get me started on all the meds for weight loss. I'm telling you right now, if a patient takes digoxin, they have a heart problem. And you already know it's a rapid heart rate. Whether it is steroid induced, from all the inhalers, all these patients that are given all these inhalers and steroids for their COPD, they end up with a resting heart rate of 142 because of all the steroids. And we talked about how steroids work, right? And we'll do that again when we get to steroids. Constantly creating a fight or flight mechanism in your body all the time. When you're just, hanging out watching The Price is Right, that still is what's going to happen. So we see that they're on dig, they have a rapid heart rate. That's all there is to it. Otherwise, if you gave dig to somebody that had a heart rate of 62 or 70, it would drop it to 40 or 50 because that's the nature of the med. That's how that med works. So real simple, dig, they have a fast heart rate. You already know what's going on with them. I already know that they have a cardiac history. I already want to know their cardiologist, and we're going to start looking into it because you're not on dig, for your blood pressure. That's not what it does. That's all there is to it. So amiodarone, that is another, or better known as pacerone. Come on, pacerone. What literary genius came up with that? Pacerone. You already know it's for the heart. You already know it's a pacing issue. You already know that it's an electrical issue, right? So this one says that it prolongs the action potential and refractory period, prolonging the QRS, the PR and QT interval, which if you understand, like we talked about before, from the atriums contracting to the ventricles contracting is kind of your PRQT interval. So it's prolonging the time it takes for your ventricles to completely fill, allowing them time to slow down and completely fill. So when they empty, they're much more productive. So it in turn also increases cardiac output. So that's what the action potential is. I don't know why they can't just say it in words that make sense to you, but that's really how simple it is. So, when you understand how actions work, you can look it up in the book on some medication you've never heard of, understand these words and say, okay, so all that means is that, $5 ionotropic word means force of contraction. If it's negative, it's going to slow the force. If it's positive, it's going to increase the force. It's that simple. So with amiodarone, it's going to slow it down and allow it to completely fill and completely empty, increasing cardiac output. So there's already some electrical issue. So when we talk about the PR QT interval, that's an electronic thing because the EKG tells us that. So it's working electrically to slow those things down and make the heart more effective. So when you are on amiodarone or pacerone, you have a heart problem. And I still get patients that are in a complete denial about it. They're like, oh no, I had a heart issue a while ago, but they done took care of that. And I just keep taking this pill, right? Because if you stop it, there's a good chance that your heart's going to go right back to that rhythm. And they never know what the rhythm is. They never ever know what. Once in a blue moon will I have somebody say like, oh yeah, I had a run of SVT when I was on this diet, this weight loss pill or whatever. And I was like, oh my God, thank God this lady actually paid attention when they talked to her. But otherwise, don't hold your breath. Sotalol, we talked about that a little bit with our beta blockers, also known as flecainide. It causes a blockade of beta 1 and 2 receptor sites. It's an antidysrhythmic, prolongs action potential. Same difference by slowing down the heart. It allows it to completely fill, completely empty in myocardial fibers and affecting conduction, prolonging the QT intervals, no effect on QRS duration. So when if I had been smart enough and didn't have a hectic day, good Lord, if my life doesn't slow down, I thought being off 2 days a week would slow things down. It has not. I would hold you up a little PQRST here and show you where they work. And when we get to rhythms, and I'm going to go over rhythms, and I still don't know how that's going to work. I hope it makes sense the way I can kind of draw it or back up my camera and make some room here. I don't know. But if I can at least give you an idea of how that works, it'd be a little bit easier to show you exactly where in that electrical route that the heart takes, that electrical path, through the woods that I was kind of explaining to my students, where you're looking for that, and you're just kind of viewing it from those different angles, and that's what an EKG is. Procainamide is another one. It depresses excitability of cardiac muscle and slows conduction, velocity in the atriums, the bundle of His, and the ventricles, increasing the refractory period. So they all kind of work very similarly. They just are a little bit different in ways that it depends on what the patient needs. And it's really not rocket science. And I know those words are really confusing sometimes, when we talk about refractory period, and it's almost like learning another language. When you know that $5 word just means this, resting period. Okay, well then that means allowing the heart to completely rest before you ask it to start again. It means you're going to get a better response from it, and then you're not going to cause the damage that constant AFib or resting tachycardia would cause. Allowing that heart to completely fill, completely empty, become effective, become rhythmic, you've got a better chance of that heart lasting a lot longer. So that's what these antidysrhythmics do. So that's DIG, amiodarone, and procainamide. We already talked about cardizem in that calcium channel blocker way, and the same difference. Like I said before, it's going to slow the influx of calcium ions across the cell membrane of the heart, slowing down that erratic electrical activity. So it's kind of like going shh to the heart. Take it easy, cowgirl. Calm down, completely fill, completely empty, big deep breaths. It's going to be all right. That's kind of how these meds work, and in turn allowing the heart to be more effective, efficient, and not causing induced workload or greater workload on that heart, hoping to prolong its lifespan. Same difference when we put use medications to decrease the workload of the heart, like carvedilol, Coreg, by opening up that aorta, allowing it to rest and relax and kind of widen so that heart doesn't have to push against that pressure. So anytime you see somebody with left ventricular hypertrophy, and you're going to see a lot of cardiomegaly, you know that heart has been pushing against pressure, whether it is pulmonic pressure or aortic pressure, and or they've had cor pulmonale or whatever long standing incidences that the heart had to push against all this pressure. Had you fixed the problem to begin with, you could have saved the heart. So those types of things, vital signs and regular EKGs, just knowing how the insides are going, a lot of these things can be prevented, especially uncontrolled hypertension, which I still see a lot. And sometimes I feel like I'm in a rotten hell when I don't say anything, and we're in a hurry and I don't want to deal, and I just kind of move on and just write the numbers down and hope they can do something about it. I had another little good talk with somebody this past week, and I think I maybe have made a little headway there, and hopefully they understand that it is something that is fixable, whether you fix it with meds or some other way. It is in fact fixable. So that's it. I'm afraid this is going to shut off any second, so I want to stop it while I can. I guess my pet peeve I was going to use this week is I watch a lot of videos on and I need to stop. I watch a lot of interview videos, and the interviewer will actually say, all right, we got about a minute left, but let me ask you your opinion on this. And they're like, okay, well, real quick. And then they rattle on for 10 minutes. So anytime I know that someone says, hey, real quick, and I say it too, I'm guilty of it also. Hey, real quick, and then a 20-minute conversation ensues. So that's about it without getting into too much detail. I'm trying to keep these quick. I was told that most people have a 15-minute attention span, so that's the best it's going to get. But the good news is if we keep it 15, I can do this forever, because I can talk for 15-minute intervals on this stuff for years. We're going to talk about stool softeners and laxatives. Next week, I think we'll do diuretics, because that's kind of all in the same issue. We'll get into antispasmodics, and then even antibiotics, and there's a couple others down the line we'll touch on. But for the most part, I want to teach you to fish. Read the action of the medication. Look up big words you don't understand, and you read them frequently and check on them again. And there's still some things I have to look up over and over, and I get it right in my head, and then I'm like, dang it, wait, what was that? Do I have it backwards? And I have to look it up again. It's just the nature. That's just how it goes. You should be learning something new every day anyway, so don't let it upset you if you have to, keep looking it up. And there's just certain things that are just tricky, and, hopefully it'll stick at some point. Okay, well, as always, face your fears, forget your failures, follow your faith, hugs and kisses. Hey, look at that, almost right at the 15-minute mark. I'm getting good. It's going to take 20 seconds to get this to stop anyway, so I'm going to, come on. No, it's not going to work. I need to just, all right, I'm just going to reach out and touch someone. Piece of crap.